Okay, so we're going to be talking about spinal cord injuries, and you can see I've got a trunk showing here, and you see that we've got the 7 cervical vertebrae, and 12 thoracic, 5 lumbar, and 5 sacral, and then the 4 that are fused coccyx. Looking at all of these and some of the problems that can show up with them. This is just looking at each vertebra, and it consists of the body and the arch, and the spinal cord passes through an opening in the center of each of these, and each arch has articulating surfaces which are the adjacent vertebrae smoothly glide with movement. The discs, the vertebrae are separated by discs, which serve as shock absorbers in the vertebral column, and they're composed of annulus fibros and nucleus pulposus. And let's see, as we age, the nucleus pulposus loses a lot of its water, and it's less effective as a shock absorber. So, bony column then is supported by muscles and ligaments and permits mobility and flexibility. Okay. Spinal cord extends from the brain stem down to L2 in the pelvic cavity, and there's 3 protective meningeal layers: the dura mater, that's the outermost; the arachnoid, the middle layer, and that's the part that contains the central spinal fluid; and the pia mater, that's the innermost, and that covers directly the spinal cord itself. And so cerebral spinal fluid circulates to the brain and the spinal column, bathing and protecting the entire nervous system, central nervous system. Okay, and that's just showing you a cross section. This tells you the 4 major spinal tracts. You can look over those if you'd like. I don't think I'm going to ask anything about that, but it kind of helps you to sort of understand and what's going on with the cord and all. Again, a page looking this shows a herniation actually, so you can see here this is how it normally should look, and here's when it's herniated. Got this picture a little before the card a little bit, that one too, but just giving you an idea. Surprisingly, the tests that you're going to be looking at are the things that we've already been doing, taking a history, neurological exam. Certainly the physician's going to do a much more detailed one, or the practitioner, than the one we do. The imaging, not anything new and exciting there. We know about all these tests, so I'm going to breeze over them, and then we'll kind of focus on some interventions that we'll be doing. Some of the same stuff. There will be some non-surgical interventions that we will do, and more conservative type things, and then there will be surgical interventions. So we'll discuss those a little bit. Of course, most of the injuries that we see come from some kind of a source of a force. So be that a car accident or a gun, a knife, those type things. Spinal cord injuries occur with significant force so that the patient can have neurological deficits. And there's about 250,000 to 500,000 people that have to be hospitalized in the U.S. every year with spinal cord injuries. Okay. There's a lot of typical things. Could be that young people are involved, but old people are involved, children. It's just really astronomical and very costly in many ways, not just in dollars, but costly. You can see here that the leading cause of trauma is the leading cause of problems with the spinal cord. Almost half originate from motor vehicle accidents, almost a quarter of them from acts of violence, which would be either fights or gunshots or stabbings, what have you. 22% from falls, and sports injuries account for 8%. I would have thought it might have even been higher. Of course, some other causes can be the growth of tumors, or things that congenital things such as spina bifida, and even things that are acquired like polio. Okay. Also, what can happen when these incidents happen? We can have this list here is hyperflexion, hyperextension, axonal, and vertebral compression. We'll look at rotational things, and we'll look at some of these. Those would be the primary cause, what happens, and then the secondary cause would be what happens after that injury is that we can have neurogenic shock, insult to the vasculature of the areas, hemorrhage, ischemia, and of course fluid and electrolyte imbalances. So we'll kind of touch on some of these. We're just scratching the surface. So get an itch and scratch. Looking at cervical neck pain, and that's not an uncommon thing. It's not the most common problem with the spinal column, but it certainly is a prevalent one, and I know y'all probably have hunched over looking at books and reading and working on the computer, and you get a stiff neck and all. Hopefully we won't require any surgical intervention, but maybe massage or traction or something would probably help us, or wearing a cervical collar to help stretch those vertebrae out and giving them a break. Pain can be from muscle spasm, poor posture, aging, improper lifting, tumors, all sorts of things. The most often area of the neck that's involved is C5 and C6, and usually what it is a herniated disc, so that can be fixed. Other things that happen are osteoarthritis, so symptoms are usually like numbness and tingling that affect the arms, and sometimes we can see motor manifestations also if it's not taken care of. Of course, education and prevention is the best thing, and we can also do some medications for inflammation and that sort of thing. So there's a chart on 46-6 and 46-7 that you might want to look over. And we might sometimes, for these problems, we may have an anterior discectomy, and that would be where they go through the front of the neck and do repair. They can also do fusions in the neck. They can also come in from the back, depending on what part of the cord is involved. And certainly, anytime we know that initially, not forever and ever, amen, but initially we are going to have the first things we're going to be really concerned with are their airway, because up in this small area you get a hematoma and it's liable to press on your trachea. So we want to watch that for that always initially, and then the rest of it of course comes with, we certainly don't want them to be paralyzed and that sort of thing. We're hoping that they get the movement back in the arms and the numbness goes and everything else works great, because the higher the injury, the more likelihood there is of other organs, the rest of the body being affected, obviously. Okay, and then we're moving from that. We're going to just hop way on down to the lumbar sacral, because that's really where we do see a lot of problems with low back pain and chronic back pain. Very high incidence of this for a variety of reasons. 85% of the population has had low back pain at some time, and of course about 85 or 90% of those are adults that are 50 and older, and they have degenerative spine problems going on, which is not unusual. The acute low back pain can also be from muscle strain, ligament strain, disc degeneration, or the herniated disc, the herniated nucleus pulposus. Usually these occur, the most common place is L4 and 5, can be above and below that. Once they are repaired, they can also have it above and below and in that same area. Sometimes they'll have to go in and do a lost my train of thought. Fusion. It just left me. Oh, so and it's considered chronic back pain if the back pain continues for 3 months or more. Okay. And when patients have these surgeries done, discectomies, laminectomies, whatever you want to call them, it's important. Years ago they stayed in the hospital a week, and we might log roll them and what have you. But now they are done, most of them outpatient, and so like with other outpatient things, we make sure they're able to take in fluids, all that sort of stuff. Their gag reflex is back, certainly before we start feeding them. But before they can be discharged, they usually have to be able to pass urine. And so that's an indication that their bowels and their bladder are okay, that they can urinate. So that's a must, because if they can't, then that may mean that there's some damage going on. So we certainly also want to look at their wound sites, which are usually small, and see that there's not any clear drainage or excessive bloody drainage even, but in particular clear, because that could be spinal fluid leaking. Okay, so we'd have to notify the surgeon about those kind of things. Looking at what some of the things that can cause some of these injuries: hyperflexion, so that would be like from hitting a wall and forces your neck to go into hyperflexion, the cervical spine. Hyperextension, compressing the cord. Axonal loading or compression, see that. And certainly we have all of these, and we certainly have these diving incidents all the time. And with summer having just been here, we've probably known of some. Okay. Rotational, that's where maybe somebody jacks this guy's jaw and gives him a sock in the cheek, and it spins his head around. Not around, but you know what I'm saying. Be lateral, might get T-boned in a car, whatever. These can cause some really exceptional injuries. Okay. Moving along. Speed of light. Okay. Of course, it depends on the extent of the damage. We don't have to have complete severance of the cord. It can have incomplete, and these are just some of the injuries that we can get. So that the posterior cord can be affected, the anterior cord can be affected, the central cord can be affected, and also there's something kind of strange called Brown-Séquard syndrome, and I'll talk a little bit about those. What happens with the anterior cord, it's caused by injury to both the gray and the white spinal cord, that matter in there, the gray and white. Typically it's caused by herniation of the disc, which occurs with flexion injury or dislocation of the vertebrae. And what happens is that they have bilateral loss of pain and temperature perception, and also motor function below the level of the lesion. So that's anterior. They have loss of bilateral pain and temperature perception, and also loss of motor function. This is below the level of the lesion. Okay. Sometimes they may have sensation and touch and vibration, preservation, but without the loss of the sense, of some of the touch and all. Usually about 20% of these will recover from that. Now with the posterior cord, and I'm not going to get real in depth with this, just that you kind of understand there can be complete and incomplete and a variety of things in between there. Posterior cord's just the opposite of the anterior lesion. They have a loss of touch, sensation, vibration, and also loss of sense of position. But they temperature, pain, and motor function below the cord of the injury level is preserved. So with the posterior, they lose touch, sensation, vibration, and sense of position. But temperature, pain, motor function are all intact below the level of the injury. With the brown cord, that's kind of an interesting one because that's where the spinal cord is injured so that half or hemisection of the cord, and so it affects only half of the cord. So depending on what side, so if the side of the lesion is the right side of the cord that's affected, well then the motor function, proprioception, vibration, deep touch sensation are lost on that same side, on the ipsilateral side, okay? And on the opposite side, the contralateral side, they have the sensation of pain, temperature, and light touch are affected. So it's kind of interesting that it kind of flips. So if I have any kind of question on there, believe me, it'll be something very, very simple, because I think that is kind of a hard concept. Okay? And this, you're familiar with this from your homework assignment, so I won't go into it, but I would think that you should know those things for the rest of your nursing career. Those are important concepts. And I know it says 8 cervical, but some books say 8, some say 7. So we're not going to quibble over that. And these next two things are just some charts. If you want to test yourself to see if you know what they are, you just jump right on it. This is just a cartoon looking at the way the spinal cord injuries that can happen. Certainly the higher up we go, the more things that are involved, and certainly a C4 and above, we know that's paralysis of respiratory muscles and the diaphragm and all, so they're going to have to be assisted with breathing. Also, just even below that, C5 and 6 can get such an injury and cause edema that it can act like a C4 for a while until that edema subsides. So we're always very leery of those, those high up in the C's. And the terms quadriplegic, tetraplegic, paraplegic, and all that. So the higher the injury, the greater the loss of function. And also these people will always have temperature regulation problems at the levels below the injury. Just something that we see a lot of. Okay? So of course, emergency things are we're gonna have to look at them a little different. First priority is going to be respiratory system always, and then as the patient progresses, then we won't be as worried about respiratory. We'll be worried about mobility and all that. But the first priority is going to be respiratory, and then we're going to have alignment and mobilization or immobilization, spinal shock, neurogenic shock. We're going to talk about autonomic dysreflexia we're going to touch on, and always we have to survey for other injuries as well, because that's not uncommon that people will have other injuries. And then you also look at whether they're old or young, do they have other comorbidities, other disease processes going on. So our job is big. And looky here. What test things we're going to look at? Oh my goodness, it's everything we already know about, so we're not going to spend a lot of time on that. I will mention that the myelograms are not done nearly as frequently as they used to be because they can do the MRIs and they can do MRAs, magnetic resonance angiography and all. So, there's other tests that can give them better results, and also the myelograms, not wrong to do them, they're just not done as often. This is just looking at every assessment of everything is going to have to happen. I mean, these are going to be total care patients, and often, and they need really strong scrutiny in the assessment category. So we're going to be looking at, can they feel, can they move? Cardiovascular certainly is affected. Respiratory. In fact, patients used to die more often from renal failure when they had these major spinal cord injuries, but that has been taken better care of in recent years, I guess, and now they are more likely to expire because of respiratory problems, because of aspiration, or because of pneumonias and that kind of thing. And do you think, I mean, all these are going to be important, and we're going to look at all of them. Do you think there's going to be much psychological problems going on with some newly quadriplegic or paraplegic? Yeah, I think that's going to be a major role change, and family dynamics changing, going to be major. So always going to be some psych things that can be looked at. All right, so looking at some of the non-surgical things that we can also see. Now with the halo and the halo fixator, that would be used for cervical stabilization. So fractures that are unstable, if they can't go in and just repair it or go in and fuse it, then they will put them in a fixator that I think I've got a picture here in a second. So we'll have some responsibilities to that. Also, some of the different Crutchfield tongs, Garner-Wells, Barton, or Crutchfield, all kind of similar. It's where they will put pins into the head and put traction, counter traction, to really stretch the spine out and hopefully not only give it some rest, but decompress some places that are being compressed. So those we don't see as much around here, but we do see the halo fixator a fair amount. For surgical things, we lots of times see laminectomies. I'm sure you probably have some family members, or some of you may have even had laminectomies. Like I said, they are a in and out kind of thing anymore, where they used to have to lay in the bed and be log rolled and what have you. And certainly they have to if they've got several fractures that have not been repaired. But when we're looking at doing the repair on them, they usually don't have to lay around too much. They generally are able to get up, not doing stooping, squatting, and what have you. But they are usually discharged pretty frequently. And again, remember, we have to make sure that they can urinate. They may have to have a fusion, and now that we might have to use some guarded things with them when they're being fused, because we don't want that to turn loose. Also with the Harrington rods, that's where rods that they put at the end of the vertebrae to line up the vertebrae and to stabilize it. Sometimes they will use that not only for a bunch of fractures, but also for scoliosis kind of patients, severe scoliosis and what have you. So those are inside the body, so we're not going to be doing anything except for looking for infection and what have you. Now with that halo, and I think I've got a picture here. There you go. There's like 4 pins that are put into the skull, 2 in the front, 2 in the back. And then all this apparatus is hooked to this vest that is snugged up on the patient, and we have to watch for bony prominences and problems with rubbing the skin and everything. But that's what keeps the spine, see how it keeps it in alignment. So, this needs to be snugged up on them all the time. Now what we will do the pin care, and we will ambulate the patient and that kind of thing. But what we don't do is screw these or loosen them or tighten them or any of these other apparatus. The physician does that. So all we do is pin care around it, cleaning with maybe peroxide and saline, and then maybe they might use betadine, they might use Neosporin, whatever your hospital uses is what you'll do. But we'll do that a couple of times a day until that kind of heals up. So. And what we do not do is we do not grab hold of these bars to help them get up. No, 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 no. It's like, remember the spica cast that had the bar in between the legs, and you didn't use it to help turn the patient? Well, you don't use these to help pull or twist on the patient. No, 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 we don't do that. Okay? Good. Excellent. Okay. Some of the meds we might see on some of these injuries. Let me see. Solumedrol for the inflammation, certainly. Dextran, we might use that to help, say, plasma expander, and we might use it to help expand the blood so that we can get good flow to the capillaries and all, so these injuries can heal. Sometimes, we have, with these injuries, we might have problems with dysrhythmias, with the heart slowing. Now, if they're not having symptoms and their heart rate's running 50 or 60 and that's normal for them, we're not going to do nothing to them. But if they're symptomatic, having a low pulse, we'll probably give them some atropine to speed it up. But we get that kind of a vagal response sometimes, and our heart rate will drop down. But symptomatic would be dizzy or fainting, or any kind of syncope, or if they get confused and they can't, the brain's not working good at that slower pace, then we'll give them something to bump it up. Same with hypertension. We will probably give something to help bump that up so that we can keep the blood flow going great. Baclofen also, because anytime we have these injuries, spinal cord injuries, often we will have some horrific spasms. So they may give baclofen like IV, and one thing we certainly would not want to do is stop it abruptly after they've been on it for a couple of weeks or even longer than that. We wouldn't want to abruptly stop it because they can have hallucinations and seizures. So, and that's not the only drug they use. They'll use other medications as well, like I'm trying to think, Flexeril or Robaxin, some of those that aren't quite as big guns as baclofen, but a variety of those would be used. And of course, as everybody knows, just about anybody that has any major catastrophic event medically or surgically going on are going to need something for ulcers. So often these folks will be on Tagamet or Nexium, or Pepsid is one that we use a lot in this area. So we can look for that. And also we know that they're going to be somewhat immobilized, so we're going to have to beef up their nutrition and also not only beef it up, but boost it with fiber, give them a lot of hydration, and because we want to keep the kidneys working as well, and also probably stool softeners because we don't want them to be straining. And immobility brings on its own set of problems with integumentary. Every system is affected all the time, so we know that. So anyway, those are some of the things we may have to do. We will have to do. So, acutely, certainly we are always concerned with the airway, and then whether we're having to do something for shock syndrome going on, or preparing them for surgery, caring for them post-op, chronic things, not so much the airway unless it is a higher injury, in the cervical spine or something, but or even thoracic, because the thoracic muscles will be impaired, and that impairs breathing and the ability to cough and deep breathe and keep your own airway cleared and that sort of thing. So that may stay a problem, but we know mobility or immobility is going to be a problem. How do we go about promoting self-care and teaching them and the family members or significant others what needs to be done and ways to help these folks? And certainly bowel and bladder training, I'd look back over that, because patients will certainly, if the higher up, not only is the respiratory system and all, but all the lower organs are affected as well. So that be the GI and the GU, the limbs with mobility and what have you. So bowel and bladder training for any of these patients is going to be a big deal, even on down in thoracic and even the lower and in the lumbar areas for certain. So everybody is going to have some of that probably, or at least have it checked on. They may maintain and do great, but we need to make sure, it's our responsibility to make sure that they are doing great. Okay? Certainly safety in other ways too. The bed in the low position, the wheels locked, all those kind of things. Side rails possibly up. Okay, moving on. All of that. And not only for the patient, but that's going to be safety for us too. And now something that I want to really hit on is the autonomic dysreflexia. And this is usually for patients, and it goes forever and ever, amen, for these patients that are at T6, have an injury, spinal cord injury at T6 or higher. Okay, so that's a whole lot of folks. And what happens is that autonomic systems kicked in, and dys, meaning not working right, reflexia. So they get a weird response to stimuli. Okay, so that's what it's triggered by, is just regular stimuli like constrictive or restrictive clothing, or a belt too tight, or shoes tied too tight, socks that have ridges in them, a full bladder or a UTI, pressure areas, an impaction, something that simple can cause, where you and I, we have any of these problems and we're like feeling miserable if we have are constipated or have a sore on our hiney's, or our shoes are too tight. And so what do? We go, oh, this is killing me. I have got to get relief. And you go and do whatever you have to do to get relief. If that's take your shoes off, untie them, loosen them, whatever. Because you recognize that you've got that happening. You can sense it, you feel it, and you get down, you reach down, and you fix it. But these folks don't have the sensation. They don't have the mobility. So they don't know. So what happens is this acts like a noxious stimuli for them, and they will, don't know that's even happening. This just comes on them real quick. Their blood pressure goes sky high. They have a flushed face, headache, neck veins distended. Their heart rate slows. They're diaphoretic. This is all above the level of injury. So they've got vasodilatation above it. While below the level of their injury, they have vasoconstriction, so they're pale, cool, no sweating going on. And this is really a big deal. So we've got to figure out what the heck's going on pretty quick. So the first thing you can do is, if they're lying down, is to put them in a high Fowler's position. And then you can investigate and see what's going on. 99% of the time, it is something to do with the bladder. Either it's a full bladder, or an infection going on, or they have an impaction. So 99% of the time, that's what we're going to focus on until we can get this thing resolved. But, they don't realize. So the stimuli there, the full bladder or the constipation or whatever, sends a message to the brain that says, emergency, emergency, things are screwed up. So it's just a screwed up message that gets blown out of proportion, but they don't know it, and they can't control that. So we have to intervene, help them. We have to get their heads up. We have to check out the possibilities of these things. We might have to give them antihypertensive meds also, but usually it will level back out once we remove whatever the noxious stimuli is. But it is something that we will see in the hospital, and you certainly will see it in the home health area, because this is forever. If they have these injuries and they're alive, they are a potential for this, and these are not terribly uncommon, but they can be life-threatening because of that blood pressure. So we want to be able to know what to do for those. Okay? Thanks. Been very attentive, and I do appreciate it, and I hope this has been helpful for you. Thanks. Bye.